Good evening, everybody. My name is Amy Coote, and I'm the CEO of Maddie Riewoldt's Vision. And thank you all so much for joining us for our first patient and family educational session of 2026. So before we do start, I would like to acknowledge the traditional owners of the lands on which we are meeting. For all of you from lots of different locations, for me, I'm on the lands of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to their elders past and present, and also extend that respect to any other Aboriginal and Torres Strait Islanders who are present here today. As many of you do know, Maddie Riewoldt's Vision is the only organisation in Australia dedicated to bone marrow failure syndrome research, education, advocacy and support for patients and families. We've now committed over $10 million across 36 cutting-edge research projects and have multidisciplinary collaborations with 26 leading research institutes, hospitals and universities across Australia and internationally. We are the source of support for bone marrow failure syndrome patients and families through our national support services, which include our tele support service, our peer support program, and our educational programs. So we now have worked with over 170 patients and families across Australia. And for those of you here tonight who have not connected with either our tele support or peer support programs, please do reach out to us because we are here if you need us. So our program this evening will focus on diagnosing bone marrow failure syndromes, including how family history patterns and genomic testing can help uncover underlying causes and guide personalised care and how at-risk family members can be supported. So following the presentations, we'll have a Q&A session. So I hope you've got some great questions ready for our presenters. Thank you to those of you who did submit prior to today. Those questions have been shared with our presenters and they will endeavour to cover these in their presentations tonight. But there'll be an opportunity to put questions in the chat or even join us for those questions a little bit later. So I now have the pleasure of introducing our first speaker, Erin Good. So Erin is an Associate Genetic Counsellor in the Haematology Genomics Service at the Peter MacCallum Cancer Centre. And Erin will be presenting on genetics, inheritance and family considerations in inherited bone marrow failure syndromes. Thank you so much, Erin.
Thanks, Amy. Now, hopefully you're all seeing the right slide.
That looks great, Erin. Thank you.
Fantastic. So thanks, Amy, and thanks all for having me. As Amy said, tonight I'll be talking about the genetics, inheritance and family considerations in inherited bone marrow failure syndromes. And just to start, so a bit of an overview of what I'll be covering this evening. And my hope is really that I can provide you with some of the key terms and concepts that are relevant when thinking about genetics and inherited bone marrow failure syndromes and how these guide our approach to implications for families now and in the future. So firstly, I'd like to do a bit of a genetics 101 to go over some of the basic terms we use every day and that Piers and I will use tonight, but appreciate that sometimes genetics can be a little bit like learning a second language. So DNA is the code inside all of our cells that tells the body how to grow and function. Within that very long code or sequence is our genes, which are like individual instructions for specific jobs in the body. We all have 20,000 odd genes, all doing different jobs. And so to contain all of that in our cells, our DNA is packaged into structures called chromosomes. And together, all of our chromosomes and genes make up our genome. So our genome is essentially all of our genetic information. Sometimes there can be a change in the DNA code. The technical term for this change, or sometimes you might heard us call it a mutation, is called a variant. And we all have variants. They're what make me, me, and you. But when a variant affects how a certain gene works, that's what can lead to certain health conditions. And lastly, when we talk about the germline, we're referring to the genetic information we're born with. And so that's the part of our DNA that can be passed down to future generations. So inherited bone marrow failure syndromes are a very diverse group of rare genetic conditions, as you'd know. I've listed a few of the groups of conditions on this slide. However, this is by no means exhaustive, and some of these groups can be sort of grouped further, and many of them overlap. These conditions are caused by many different genes that are important for helping the bone marrow make healthy blood cells. But many of them also play key roles in other parts and cells in the body, and that's why some of these conditions can affect people in different ways. In terms of which genes are associated with inherited bone marrow failure syndromes, our knowledge has expanded considerably. So back in around 2010, the list of genes would have looked a little something like this. And now the list looks a little more like this, and it's continuing to grow all the time. And with this expanding knowledge, it helps us diagnose more individuals and families and better understand the different ways these conditions can present. But given the long list of genes and associated with inherited bone marrow failure syndromes and the variability we see both within and between these conditions, identifying the causative variant can sometimes feel a little bit like looking for a needle in a haystack. And so one of the key steps in the diagnostic pathway is really taking a close look at personal and family history. And this helps us assess whether an individual's bone marrow failure is more suspicious of an underlying genetic cause rather than something acquired. So on the personal side, we start with the obvious things like blood counts and bone marrow findings and some of the screening tests for Fanconi anemia and sort of telomere length testing. But we also explore a broader medical history, as well as some of the features or symptoms that can appear in syndromic conditions. And when I say syndromic, I mean conditions where it's not just sort of changes in the bone marrow or the blood, they can present with other features. And this can include sort of differences in height, sort of differences in sort of skin, nail or hair, and sometimes sort of limb or facial differences compared to sort of other family members. So family history gives us another important piece of the puzzle. So of course, we want to know whether any relatives have had sort of low blood counts or been diagnosed with bone marrow conditions, and sort of acknowledge that you might not know your relatives' full blood counts, but clues like easy bruising or frequent infections can be really helpful for us too. We also pay attention to other organ issues such as lung or liver disease, as well as cancers outside of the blood system or bone marrow, and the ages to which these diagnoses might have occurred in family members. Importantly, having no family history does not rule out a potential genetic cause. And hopefully the next few slides on inheritance patterns will help explain why this may be. So firstly, we all have 2 copies of every gene for the most part, one from each of our biological parents. In autosomal dominant inheritance, having a variant in just one of these copies is enough to cause the condition. And this means that an affected individual has a 50% chance or 1 in 2 chance of passing the variant on to each of their children or future children. And when a variant is confirmed to have come from from a parent, each of that sort of affected individual siblings we'd say has a 50% chance. So examples of autosomal dominant inherited bone marrow failure syndromes include Diamond-Blackfan anemia, some telomerase disorders, and sort of GATA2 deficiency. I've marked sort of DBA and telomere disorders with an asterisk, and that's because not all of the genes associated with these conditions follow a dominant pattern. So the presentation of dominant conditions can vary widely, even within the same family and between sort of 2 family members with the same variant. So for example, in DBA, we know for some families, a child can be diagnosed with DBA and have a causative variant and sort of present with symptoms and sort of need transfusions and have no family history. But when we test the parents, we discover it's been inherited from a parent who's never developed symptoms. Another reason someone may have no family history of a dominant condition is that the variant has occurred in that individual for the first time, and that's what we call a de novo variant. And in DBA specifically, we know that sort of around 2/3 of variants are de novo. And with that, just to note that de novo variants are not exclusively to dominant conditions, but we do see it there. So Next up is in autosomal recessive inheritance. And this inheritance pattern works a little bit differently. So we still have 2 copies of the gene, one from each biological parent, but in a recessive condition, both copies of the gene need to have a variant for someone to develop the condition. And so if a person has a variant in just one copy, they're what we call a carrier. Carriers don't typically have any symptoms and are likely completely unaware that they're a carrier. And that's why autosomal recessive conditions often appear in families with no prior history. Examples of autosomal recessive bone marrow failure syndromes include Trochman-Diamond syndrome and Fanconi and some types of severe congenital neutropenia. In these families, each pregnancy has a 1 in 4 or 25% chance of being affected, a 50% chance of being an unaffected carrier like each parent, and a 1 in 4 chance of inheriting no variants at all, no sort of causative variants at all. For someone who has a recessive condition, their children will at least be carriers because they can only pass on the copy of the gene with the variant. The chance of having a child with the same condition is really dependent on where the other biological parent is a carrier. And that chance is usually low, but there are screening options available to better understand that risk. The third and final inheritance pattern I wanted to cover tonight is X-linked recessive. So females typically have 2 X chromosomes, 1 from each parent, while males have 1 X from their mother and 1 Y chromosome from their father. In X-linked recessive inheritance, the genes associated with the condition is located on the X chromosome. So therefore, if a male has a variant in an X chromosome gene, they're usually affected as they don't have that second copy of the X chromosome to compensate. Whereas females have two X chromosomes, so if they have a variant on one copy, the second copy acts as like a backup, and they're usually considered carriers. Examples of X-linked recessive conditions in inherited bone marrow failure syndromes include telomere biology disorders caused by the DKC1 gene, sometimes known as dyskeratosis congenita, or bone marrow failure caused by variants in the GATA1 gene. So for carrier females, each pregnancy has a 50% chance of inheriting the variant. But as I mentioned, sons who inherit it will typically be affected, while daughters are likely unaffected. For males with X-linked recessive conditions, if they were to have children, all of their daughters would be carriers and males would be unaffected as they're only getting that X chromosome from their mum. So moving on to sort of the implications for wider family and how we sort of put that into action, I wanted to use a sort of a fictional example, the Smith family. And although this is a fictional case, the concepts are very similar to what real families experience. But before I get into the Smith family, it's important to say that who we offer testing to, when, and sort of, what family members are relevant to offer testing to is really dependent on the specific condition, the sort of the gene involved, and the family circumstances. So the approach may differ from family to family. So in this case, the first person we meet is Tim. Tim has been diagnosed with a telomere biology disorder, and genetic testing has shown he has a causative variant in a gene called TERK. And TERK follows an autosomal dominant inheritance. There is a little suggestive history on Tim's mum's side, but we can't know for sure whether he's inherited this from a parent or whether it possibly could have occurred de novo in Tim. So for that reason, where practical, our first step is to offer testing to an individual's parents. And so testing in Tim's parents confirmed he inherited the variant from his mum, Mary. This helps us understand who else in the family may be at risk. For the Smiths, the next people to offer testing to are Tim's siblings, Michael and Sarah, who each we'd say has a 50% chance of having inherited the variant. We would also consider Mary's brother Jim. while it's possible the variant could have arisen de novo in Mary, we can't test her parents, and her mother's history of lung disease raises some suspicion of a TBD. So for Jim, we would typically quote a 50% chance as well. So after testing the family, both Sarah and Jim were negative, meaning they have not inherited the variant. For Sarah, that also means she can't pass it on to her children, so testing them isn't indicated. Michael, however, has inherited the variant, despite not having any sort of symptoms or manifestations at this stage of a telomere biology disorder. So for both Michael and Mary, knowing that they carry the genetic variant allows us to guide their care more effectively. It means we can offer sort of targeted assessments and proactive screening to pick up any sort of early manifestations and act early if anything does arise. And lastly, for both Tim and Michael, who are sort of at an age when they might be thinking about their own family, knowing the causative variant helps guide conversations around reproductive options if they are family planning. And so that leads me to my final point, which is how this information can support family decisions more broadly. So understanding the specific variant can open up several reproductive options. This includes carrier screening for a partner to clarify the chance of having a child affected by an autosomal recessive condition in the family, as well as the potential option of pre-implantation genetic testing by IVF, which involves selecting embryos that haven't inherited the variant. Also prenatal testing during the pregnancy to understand if the baby might be affected is also possible, as well as exploring other pathways to parenthood. And really most importantly here is that there's no single right choice. The best option is always the one that aligns with your own values and family circumstances. And a reproductive genetic service is somewhere that you can speak to a genetic counsellor like myself, who can sort of help guide you through those options and work through that decision-making process. And so just to sort of summarise the things I've sort of gone through tonight, inherited bone marrow failure syndromes are linked to an ever-growing number of genes, and we're learning more and more every year. When we're assessing whether an individual may have an underlying inherited bone marrow failure syndrome, we look closely at their personal and family history. However, it's important to remember that a lack of family history doesn't rule out the possibility of a genetic cause. And sometimes these genetic conditions can appear for an individual for the first time in a family. Understanding how these conditions are inherited helps us identify who else in the family might be affected now or in the future. And even within the same family, people who share the exact same variant can be affected very differently. Some may have clear symptoms and clear presentations, while others may not have any at all. When we're able to sort of pinpoint the underlying genetic variant, it can help guide us in terms of being offering more proactive screening, monitoring, and treatment. And it can also support individuals and families in making family planning decisions. That's me. Stop sharing.
Thank you so much, Erin. Excellent presentation. We're so grateful for you bringing your expertise to us this evening. I now have the pleasure of introducing Associate Professor Piers Blombury. So Piers is a clinical and laboratory haematologist and lead of the molecular haematology service at Peter MacCallum Cancer Centre here in Victoria. Piers will present germline testing and molecular diagnostics in inherited bone marrow failure syndromes. So over to you. Thanks so much, Piers.
Thanks, Amy, and thanks for having me. I'm just going to rely on young Erin to share my... Oh, no, share to send my slides. Very good. So my name's Piers. I'm a haematologist. I run the molecular laboratory, primarily involved in all the testing of patient samples to try and work out what the diagnosis is, which genes are affected. I also work in the bone marrow failure syndromes clinic, with Dr. Lucy Fox and a few other people who you might have met, and Erin and Nicole, who's on the line as well. But my brief today is really to talk about how we actually work out and what testing is available. And some of you may have had testing, some of these tests performed, and how we actually interpret those tests and what we do with the answers once we get them, if we get them. So it'll be a relatively brief talk, but then we've got time afterwards to delve into any parts that people want to talk about more. So, what types of genetic testing are available once we've decided to have genetic testing? So once you've seen someone like Erin and had a discussion about whether genetic testing is the right thing for you, and you understand what the pros and cons of having a genetic test are, there are a whole bunch of tests we can do. And broadly, as Erin said, there's 20,000 genes in the genome. We know about 200 to 300 of them cause bone marrow failure syndrome. So what we need to do is somehow look at those 300 genes and work out whether there's a mutation or a variant in that gene which is causing the patient's condition. And so in the inverted commas old days, in fact, and in some places in Australia, but in generally in the old days now, we would look at one gene at a time. So a patient would turn up with something like, let's say, severe congenital neutropenia. The most common cause of severe congenital neutropenia is in a gene called ELANE, and we would just look at the ELANE gene and look for variants in the ELANE gene, and that would take the best part of 3 to 6 months. Sometimes it involves sending the patient's DNA to France to the ELANE specialist to have a look at that gene, and if that came back with the answer, then the patient has the answer. But if it didn't come back with the answer, we have to decide, okay, well, what's the next most common gene? And we go to the next most common gene, and another 6 months went by whilst we looked at that gene. But you can imagine that you get the law of diminishing returns as you're going down the tree, especially when there are 200 genes involved. And so then came along an approach called next generation sequencing, or NGS. You might have heard. And this has really revolutionized the way we test genes. And it allows us, previously where we could look at one part of one gene, it would take 3 months. Now we can look at the entire genome of 100 patients in 24 hours. That said, we can generate the data in 24 hours. Looking at it takes longer, but the point is we can generate all that data, and we're getting more and more sophisticated with tools to look at multiple genes simultaneously. So by far now, the most common testing done in Australia and worldwide is what we call targeted panel testing. And so targeted panel testing is where we have the patient turns up with suspected bone marrow failure syndrome, or in another condition, they may turn up with hereditary deafness, or there might be hereditary seizure disorder. And you have a panel which has got the 200 genes that are affected in that condition. And so we're talking about inherited bone marrow failure syndrome at the moment. So you would choose a panel that has 200 genes, and you look at those 200 genes simultaneously. Now, typically with this targeted panel testing, we don't look at the whole gene. We look at just the really important parts of the gene, because within the gene, there's a sort of the important parts which code for the actual instructions, which make up about 20% of the gene. But 80% of the gene is sort of this inverted commas junk scaffold DNA, which all holds it all together. And we'll talk more about that in a second. But targeted panel testing is really the mainstay of testing at the moment. But that's closely being followed now by what's called whole exome sequencing. And some of you may have heard of whole exome sequencing. Some of you may have had whole exome sequencing done. Whole exome sequencing is where we sequence and look at every single gene in the genome, in terms of we generate the data for every gene in the genome, but we actually still only look at the 200 genes we care about. But it's with the march of technology, it's actually easier to generate data for every single gene in the genome, but only look at the 200 you care about, rather than have a special panel which just looks at 200 genes. And so what that allows laboratories to do, and this is why laboratories are taking it up, is that they offer whole exome sequencing. And so if a patient turns up with inherited bone marrow failure syndrome. They sequence every gene in the genome, and they look at the 200 involved in bone marrow failure syndromes, and let's say they might find the answer or might not find the answer, and then the doctor says, "Oh no, we thought it was an inherited bone marrow failure syndrome, but actually it's probably more like an immune condition." Instead of having the patient having to have another test and have another panel performed, the lab can go back and look and just go, okay, well, now we'll look at the 200 genes that are involved in the immune system, or deafness or seizures or whatever it may be. And then some patients, turn up with a disease. We're not sure what it is. It could be blood, it could be immune, it could be metabolic, and so there are some use cases where, in fact, we look at thousands of genes simultaneously to try and work out what the patient has inherited, causing their condition. So we test all the genes known to cause gene in the genome in whole exome sequencing, but we only look at the subset we're interested in. And that's becoming more common. And to be honest, it's probably half-half now between whole exome sequencing and target panel testing that are done by laboratories both in Australia and worldwide. And then I spent a little bit of time talking about whole genome sequencing, because that's an area of interest of our laboratory, and that's some of you may know about a study we've run recently in Australia where we've offered this testing, whole genome sequencing, to about almost 300 patients now. Whole genome sequencing is where you test every gene in the genome that's known to cause disease. You test every gene in the genome which is not known to cause disease. And as well as testing the genes themselves, you test the bits in between the genes, you test the bits at the end of the genes, you test the bit that are holding the chromosomes together, you test the bits in the center which no one knows what they do, and you generate a massive amount of data, but you leave no stone unturned in the genome to work out what's going on. And this is becoming more and more common, and is clearly the most powerful way of resolving diagnostic issues in patients with bone marrow failure syndromes. All right. So to give you an idea of the scale difference between, whilst whole exome sequencing and whole genome sequencing sounds similar, there's about a 100-fold difference in the data produced between whole exome sequencing and whole genome sequencing. It's difficult to get your head around the scale of the data, but I think I worked out once that if you wrote the as you would have seen in Erin's first slide, the AGTC that makes up all our genome, there's basically 4 billion of those in the genome, which we sequence all of those in a patient with whole genome sequencing. And so if you were to put those in a Word document at in Arial and font size 10, and basically you could essentially hold down the page down key for multiple lifetimes and only get to a few % of the whole genome. So it's a completely mind-boggling amount of data we're looking at. It requires massive amounts of compute, massive amounts of storage, and high-tech sort of pipelines to sort of sift through that and work out what's going on with the patient. But it's worth it, as I'll show you in the next slide. So if you want to go to the next slide. So we performed this study over the last 2 or 3 years. We were lucky enough to get some money from the federal government through an MRFF grant to perform whole genome sequencing in patients with bone marrow failure syndromes. And at the same time as performing, and the main thing we wanted to do is work out what proportion of patients we were able to make diagnoses in compared to other testing such as panel testing and whole exome sequencing. And we also wanted to know how patients felt about this, how doctors felt about this, what were the health economic benefits, what could we discover, and what the other implications for the health service was of this testing. And so if you go to the next slide, the results were that we solved the diagnosis in 37% of patients. Now, that whilst that might sound disappointing, you're thinking, oh well, if this is the best test to do, why isn't it detecting in 90%? The 37% is a pretty good number for the field in general if you're trying to work out a genetic disease. But what you have to remember is that a reasonable proportion of patients who present with inherited bone marrow failure syndrome or suspicion of inherited bone marrow failure syndrome actually may have a non-inherited cause such as aplastic anemia, or there might be an allergy or an autoimmune condition or medication which has no genetic cause. And so we tried to weed those patients out of and not include them in the trial because that wasn't the point. But as you can see here, we solved the case and over a third, which is, essentially before then we were looking more at the 10 to 15% mark. So we've probably tripled the diagnostic value with whole genome sequencing. And there you can see in that impossible to read diagram, but we made all sorts of diagnoses in terms of Fanconi anemia, Diamond-Blackfan anemia, telomere biology disorders, severe congenital neutropenia. And what we found with whole genome sequencing is we also found both causes for blood conditions which people didn't think were actually blood, which people didn't actually know were a blood disease. So, for example, sorry, I'm just getting so people who thought had a blood disorder but actually had a thyroid disorder, and the blood condition was secondary to their thyroid not working. And so, that never would have been found in a bone marrow failure panel or a whole exome sequencing. If you were looking at blood issues, you have to look at the whole genome in an unbiased way to work that out. We also found secondary findings in patients, so things that were unrelated but sometimes explained conditions in patients. Immune conditions, history of heart problems in the family, and other conditions. So it's by far the most effective way of making diagnoses quickly, and now we just have to work out the best way of rolling that out Australia-wide in a sustainable way in order that every patient can have access to it. So if you just go to the next slide. So what do we? So Erin touched on this. So, but what do we do once why do we bother trying to get a genetic diagnosis? Why can't we just say the diagnosis is Diamond-Blackfan anemia? Why do we have to know that it's caused by RPS 19 or RPS 17 or RPL 5? And the reason is, as Erin was saying initially, it allows us to test family members. Okay, so we can't work out whether a family member may have a disease if we don't know what to test for. A lot of these, as Erin was alluding to before, a lot of these conditions can be have quite a variable presentation, and you can have people with that have the affected gene but don't have very severe symptoms that might be going unnoticed. We can tell doctors and patients about the likely outcome of the blood condition. So the gene that's causing the disease can somehow be very closely related to whether the condition will get worse with time or even get better with time in the case of things like SAMD9 and DBA, or whether it's predicted to stay the same over time. And this is only really what you can do once you know the gene that's causing it. Once we make an accurate genomic diagnosis, we can know which other organs are affected and what needs to be tested. So, for example, if you've got a telomere biology disorder, we keep an eye on your lungs and do lung function tests. But if we just think you've got a bone marrow failure syndrome, we don't know what the cause is. We don't know which organs to screen for other issues. And on the flip side, if we know what the genetic diagnosis is, we can avoid unnecessary investigations. So we had a discussion today about a history of a platelet disorder. Platelets is one of the cells in the blood, and the family that have had this platelet disorder was having multiple investigations in bone marrow biopsies to try and work out what was going on. And if we knew it was this, if we knew what gene it was, then we wouldn't have to be doing painful things like bone marrow biopsies to work it out. To inform the choice of a bone marrow donor. So as you may know, the treatment for a lot of bone marrow failure syndromes is to have a bone marrow transplant, either from a family member or from an unrelated donor. And if it's a family member, we have to make sure that the person donating their stem cells to the patient doesn't have the same condition that we don't know, and we don't know about it, because if we do, then we're just giving the patient back the condition from their family member. And then there are disease-specific therapies, so prednisolone for Diamond-Blackfan anemia, androgens for telomere biology disorders, and emerging therapies, and the most exciting of which is gene therapy. And so I know there's going to be some questions on gene therapy, but just at a high level, gene therapy essentially involves identifying the gene which isn't working properly, and then taking the stem cells of the patient and genetically engineering them so they produce a functional protein and putting them back in the patient. And obviously you can't do that if you don't know which gene is affected. So for all these reasons, apart from just the fact that we all know that actually having a diagnosis is one of the most important things to the patient and the doctor in terms of their treatment, are the reason why we want to make an accurate genomic diagnosis.
Thank Piers and Erin for joining us and for sharing their expertise. This comes up a lot in our questions with our patients and families, and it's been such an important educational session for us to learn more about this evolving area. I would also like to thank all of the patients and families for joining us tonight, and for those that did submit questions to help guide the content this evening. We really are committed to co-designing programs and ensuring that lived experience is represented in all that we do. And if we can help answer those questions throughout these sessions, then we hope we continue to meet your needs. So we will be sending a short survey tomorrow. So we'd really appreciate your feedback. It helps guide us on making sure that the sessions continue to evolve and improve. And we'd be really grateful for you to take a few minutes to complete those. So as mentioned at the beginning, tonight was the first patient and family educational session for 2026. Our next session will actually focus on fertility preservation. So that will be held on Thursday, the 30th of April. So watch this space. More information will be forthcoming shortly. But thank you all so much for joining us this evening. We're really grateful for all of your time. And as we said earlier, please make sure you reach out to either Mei-Ling or Rachel through our tele support services if there's anything else that we can provide to support you and your family. But have a lovely night. Thank you again, Piers and Erin, and we'll see you all again shortly. Good night.
Thank you for having me.
Bye-bye.